Hello everyone, my name is Stacy Firely and most of you know me as the speech therapist that covers the NICU, pediatric, and well-born units. Today we are going to talk about feeding our babies who are going through opioid withdrawal. So we're going to start with a review of the anatomy and the mechanics of the swallow in an infant. Then we'll talk about the characteristics of pre- and late-term feeders, the characteristics of the NOWS feeder, and then we'll identify signs of poor quality feeding and discuss what strategies we can use to help improve the feedings and what strategies we don't want to use. And we'll finish up with some special considerations. Let's get started. Okay, so let's start with a quick anatomy review. So here we have the lips, the gums, the tip of the tongue leading to the blade of the tongue and then to the base of the tongue, which attaches at the top of the throat or the pharynx. This is the epiglottis, that flap that comes down and covers over the entry to the lungs to prevent any food or liquid from going down the wrong pipe. These are the vocal cords and the larynx leading to the lungs. This back here is the esophagus, the entry to the stomach. And then this is the soft palate. It elevates while we swallow to prevent any food or liquid from going into our nasal cavity. So feeding is a highly complex activity because during feeding, the pharynx is forced to rapidly switch back and forth from an alimentary tract to swallow back to a respiratory tract for breathing. So it's important that all of these muscles move in succession at the right time and in precise coordination with breathing. During feeding, breathing has to stop as the airway closes off every time we swallow to allow liquids to pass through, and any slight discoordination of the cessation of breathing and the onset of the swallow can easily result in airway invasion, or what you may have heard me refer to as penetration or aspiration. I want you to remember the only time the entry to the airway is covered or closed is when the infant is actively swallowing. Otherwise, it's open so that air can move in and out freely, allowing normal breathing to occur. So while they're sucking, their airway is wide open. The only time it closes over is when they swallow that liquid. So now let's talk about some causes of feeding difficulties in our NOWS babies. In term infants with NOWS, feeding issues stem from neurologic dysregulation. In our preterm or late-term infants with NOWS, feeding issues may be related to a combination of the immaturity and neurologic dysregulation. So we need to keep the preterm impact on feeding in mind, not only when we know we are caring for our premature infant with NOWS, but especially when we're caring for a baby whose mother had little or no prenatal care and their dates are estimated, as you may be dealing with a younger feeder than we initially thought. When that's the case, we then have the neurologic impact of the exposure, compounded by the withdrawal symptoms, which are further impacted by immaturity. And so when you have a baby who's failing their EAT scores, it's important to tease out if their feeding difficulties are related to immaturity versus withdrawal, especially when the initiation of morphine is being considered, and also so we know how to better support them during feedings. So let's compare the characteristics of the pre- and late-term feeders to those of the term NOWS feeders. Okay, so characteristics of the preterm feeder. They will often show inconsistent waking and interest in PO feedings, not always showing us PO cues. They'll often have a weak latch and suck due to weak oral musculature. They'll have an immature suck pattern with short, inefficient suck bursts, generally taking 2 to 4 sucks a burst before needing a break, or the opposite, taking longer suck bursts and not stopping often enough for breathing breaks, which often results in tachypnea, early fatigue, or apnea brady or desaturation events. These babies generally have a decreased ability to coordinate the suck swallow, often resulting in early leakage of liquids back into the throat or out of the front of the mouth. And they also have a decreased ability to integrate the swallow breath sequence as the throat rapidly changes back and forth to allow for swallowing of liquids and breathing between swallows. This often results in rapid shallow breaths and or desaturations, and bradycardic events if airway invasion does occur. Although it's important to note that airway invasion may go undetected and is what we call silent aspiration, as the infant's sensory system is not fully developed at this point, the cough response becomes more consistent and effective at 1 to 2 months. So when we're dealing with a preemie, a late term, or even a term baby, we can't rely on a cough response to tell us that something went down the wrong pipe, so to speak. Instead, you may see prolonged exhalations or apneas, desaturations, bradycardia, or stridor in response to airway invasion. In terms of decreased endurance, these babies do not have the respiratory drive and energy to complete full oral feedings and require time and practice to build their endurance. And reflux, which we suspect is present in all babies to some degree, but I want to point out that commonality does not equal normalcy, and so these symptoms need to be monitored closely as they can significantly impact feeding quality and engagement. Oftentimes, caregivers will mistakenly think that a baby is fatiguing early or suspect the nipple is too slow with a baby who's shutting down during feedings, when it may be related to reflux or esophageal dysfunction that's making them stop feeding due to discomfort. So just something to think about. Now let's review some attributes we may observe in a NOWS baby that we generally don't see in a premature baby who does not have NOWS. Frantic searching for the nipple with the head moving side to side, trying to find the nipple, or crying in frustration with the inability to organize to latch onto the pacifier or nipple, even when it's in their mouth. Once latched onto the pacifier, you may see a hyperactive suck or excessive sucking. You may see lots of rooting, easy acceptance of the passy, and then a consistent and vigorous non-nutritive suck. But when transitioned from the passy to the nipple, they shut down once they begin to extract liquid from the bottle. You may see a marked difference when they have to manage a bolus of fluid. The sucking action that was soothing to them on the passy is now a lot of work and stressful, so they stop sucking. If you give them the pacifier back, you may often see that vigorous non-nutritive suck come back. These babies often have abrupt state changes when awake, which will impact feedings. As we know, they feed best in a quiet, alert, and organized state. So excessive fussiness and irritability with that external stim will negatively impact their ability to organize themselves for feedings. On the other hand, we have babies who have absent state fluctuations and may not wake for feedings. Our babies who are hypertonic will also have tightness in their oral muscles, which often results in decreased lingual coordination and jaw clenching, and both of these can lead to anterior loss of fluid. Specifically with the jaw clenching, you will actually see the liquid squirting out of the mouth around the nipple, unlike the dribbling out of the side of the mouth that we generally see when there is too much fluid in the oral cavity, or the infant is disengaging and simply allowing that liquid to flow out of the mouth rather than transferring it back and swallowing it. This hypertonic latch actually results in squirting of the fluid as the jaw clenches and forcefully pushes the liquid forward out of the mouth. So feeding differences in now babies. They might have more apneic swallow bursts, which can be a series of 3 or more swallows prior to stopping to take a breath. They have shorter, more rapid swallows with shallow breaths followed by immediate initiation of the next suck burst and a lack of realizing that they need to stop to take a breath. This often results in an arrhythmic suck pattern where we want to see a repetitive suck, swallow, breath sequence. What we'll often see with these babies is a suck, suck, swallow, 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 shallow breath, suck, swallow, swallow, shallow breath, etc. This is an uncoordinated and a maladaptive means of feeding. It's inefficient, and it increases the risk for airway invasion and may lead to further feeding difficulties as the infant matures. Even when foods are introduced, if they already have maladaptive feeding behaviors, this can impact them feeding solid foods as well. So we need to try to prevent this feeding pattern by providing the right flow rate and external pacing to ensure adequate breathing breaks are taken. In terms of signs of a poor feeding, things to look for: difficulty attaining or maintaining a latch. You may hear smacking sounds during the feeding indicating loss of latch, or difficulty attaining that latch with that frantic searching we talked about. This baby may benefit from a different nipple, potentially a wide base. You may see decreased transfer swallow coordination and audible gulping, which tells us the baby is having difficulty managing the liquid in their mouth and the timing of the onset of the swallow with the transfer of the fluid into the throat. A slower flow nipple may help with this, as it's easier to control a smaller amount of fluid. Also, decreased ability to manage a larger volume of fluid and coordinate the timing of the swallow can result in uncoupling of the swallow-breath interface, causing airway invasion and resulting in events or potentially coughing or choking. Alternatively, the infant may not have an event or a cough response, which is again what we call silent aspiration, and happens frequently in babies as their cough response is not yet fully developed. Silent aspiration events are concerning as they may go unnoticed until the infant starts to show clinical signs of aspiration, things such as oxygen drifts or oxygen requirements, which is why it's so important to watch their cues and stress signs very closely, as it's the only way for them to communicate that they are having difficulty with the feeding. Stress signs, milk loss, stridor, and early disengagement are also signs of poor feeding. So we're going to start on the rest of these by reviewing stress signs. And here we have some other examples, things such as furrowed brows, wide eyes, nasal flaring. Arching is another stress sign, pulling off the nipple, extremity extension, hand splay or stop sign, sneezing, yawning, hiccups, all considered signs of stress and is their way of saying help. And we as caregivers need to pay close attention to these signs and respond accordingly. It's also important that we educate parents on all of these stress signs, as they are often misunderstood or mistaken for something completely different. For example, extremity extension is often mistaken for just stretching and waking up. A sneeze just as a sneeze. Averted gaze as just looking around the room. And so these are things that parents don't often realize are signs of stress until we tell them. In terms of anterior spillage or dribbling during a feeding, another sign of a poor feeding. So here's an example of some oral spillage. This is kind of an extreme example, but basically any anterior loss of milk or dribbling is not considered normal and should not be observed during a feed. If you're only seeing this happen occasionally during the feed or only at the beginning or the end of the feeding, and you can provide some external pacing to limit or prevent the spillage, then maybe not so troubling if there are no other concerns of poor feeding. But if you're seeing consistent spillage throughout a feed, whether it's a small amount or not, you should try to slow the flow of the nipple. This is absolutely telling you that the current nipple is too fast and there's too much fluid for this baby to manage. I will add that there are times when an infant who has a tongue tie will have some spillage, and there's not a whole lot we can do about that besides maybe try, again, a wider base nipple. But that may be something that you see with a baby with a tongue tie that we really can't do a whole lot about. But again, we want to slow the flow so that we don't have too much spillage occurring. When you do see anterior spillage, what you want to do is give some external pacing, and there's a couple of ways that we can do that. So we can slow the flow of fluid through the nipple by allowing less milk into the nipple, and that reduces the amount of liquid the infant is able to extract out of the nipple and helps them to better manage the amount of fluid in their mouth and giving them more control. This is especially helpful at the start of the feeding, with a gradual increase to a full nipple after they have had some time to practice and coordinate their suck swallow. And this is also a really good way to introduce a faster flow nipple when trialing it for the first time. Introducing more fluid in a slower, controlled manner as the feed progresses will help them acclimate to the larger volume. And then in that second picture on the right, this is a feeder-imposed rest break when the nipple is tilted down and completely emptied so that no fluid is able to be extracted even with continued sucking, or by fully removing the nipple from the mouth, which allows the infant to take ample and adequate breaths between suck bursts. Both of these techniques will help the infant to maintain a more stable respiratory pattern and feel more relaxed and calm during the feeding, which should reduce the stress signs and the anterior spillage. If stress signs continue to be noted even with pacing, a slower flow nipple may be warranted. You don't want to have to pace a baby through an entire feeding unless you have them on the slowest flow nipple, and with the pacing they appear safe with minimal stress signs. But otherwise, we only want to pace as needed and keep it to a minimum as possible. So, stridor. Stridor is indicative of a narrowing, weakness, or irritation in the throat or the airway, and can significantly impact feedings. It may be observed with airway invasion or when tissues partially collapse under the negative pressure that's generated during inhalation due to weakness in the throat or the airway. If there's a concern that the stridor is related to weakness in these areas, then there are automatic concerns for that weakness to be impacting other functions that occur in the same areas, such as the timing of the swallow or the ability to achieve full airway protection during the swallow. We also worry about respiratory stability when stridor is present, as partial collapse or narrowing of the airway may impact proper oxygenation, especially during challenging tasks such as feeding, and may also cause distress and increased work breathing, further impacting bottle feeding attempts. Another important consideration is that stridor may be observed in relation to reflux. As the refluxed milk mixed with stomach acids re-enters the throat, the tissues of the pharynx or larynx may become irritated and inflamed or edematous, resulting in a narrower passageway and noisy airflow. It's important to remember that any degree of stridor is considered abnormal and should be assessed by the SLP as soon as it's noted, as the timing, consistency, and severity matter in terms of how to manage it. We also know that oftentimes stridor worsens rather than improves, and it should be managed in a proactive, not reactive manner, so we can tease out the etiology and the best way to manage it. Here's a couple of examples. The first video, you can see some tugging at that sternum notch. And in this second video shows just a higher pitch stridor. Both of these videos show the impact of stridor on breathing only. You can imagine what these guys would sound like during a bottle feeding. Okay, so now let's review disengagement and what to look for. Babies show signs of early disengagement in multiple ways, and it may simply be in response to fatigue, but it can also be related to difficulty or discomfort with the feeding, aspiration events, reduced state control, as with our NOWS babies, and or reflux or GI symptoms. So we may see our babies shut down and appear fatigued during a feeding. And fatigue after a duration of active feeding and not extracting much fluid from the nipple may actually be fatigue from a slow flow rate, which makes them have to work very hard during the feeding and tire out. However, fatigue early on in the feeding or after some weak, inconsistent suck bursts is more likely related to discomfort or overall difficulty feeding. They may limit their intakes if they're having difficulty protecting their airway or managing the bolus size or feeling discomfort due to reflux. It's important for caregivers to watch the infant's cues closely to try to determine the reason for the early disengagement and not just assume that the nipple is too slow and the baby is tired. You may see things like slowed or limited suck bursts or chewing on the nipple. They may also use a slowed suck pattern with only a few suck bursts followed by long rest breaks. They may demonstrate a shallow latch or weak sucks, or demonstrate a non-nutritive suck or chewing pattern on the nipple to limit or prevent extraction of fluid. You may see them pulling off the nipple, pushing the nipple out of their mouth, turning their head away when you're trying to introduce the nipple. They may simply release their latch on the nipple. You may see a laxness in the jaw with no attempt to even push the nipple out at times. You may see excessive dribbling, as we saw a few slides ago, not even trying to swallow the fluid. And you may see rapid state fluctuations. These babies may be calm and appear to be feeding well at the start of the feed, and then either abruptly shut down or abruptly become fussy and agitated. Our babies with severe reflux will often stop feeding around the same volume for days or even weeks because it's at that volume that they begin to feel uncomfortable, when they feel like they can't take any more fluid. When we have babies who are disengaging due to reflux, we often see that giving them a faster flow nipple does not make a difference in their volumes, as they will continue to limit what they're taking. Additionally, a faster flow rate may worsen the reflux symptoms by increasing their rate of intake, or it may place them at risk for aspiration. Reflux symptoms. These symptoms can vary across infants, some of them having the classic signs listed here: nasal congestion, arching, grunting, fussiness, coughing and dry swallows during burping or after feedings, emesis. Excessive saliva or drooling is generally a red flag for esophageal or reflux symptoms. And then our babies with unexplained persistent oxygen needs may also be reverse aspirating from reflux. So these are some things that we're pretty used to looking for. We have, some of our babies who have reflux are the ones we know as the happy spitters, the ones who take all of their bottles but spit half of it back up and take their next feeding like nothing happened, and we know they have reflux. And others are what we call the silent refluxers. These are the babies who aren't showing gross symptoms of reflux, but just aren't taking their volumes. They often show a lot of what I call self-limiting behaviors, or they have events between feeds, less than 60 minutes after feeds, during gavage feeds. Oftentimes, the silent refluxers are the ones who shut down during feedings or use a lot of that non-nutritive sucking that we just talked about. The non-nutritive suck bursts may likely be a strategy to use additional saliva swallows to keep the reflux down. They may swallow saliva in an attempt to keep things moving in a downward motion, and thereby limiting fluid from coming back up. Or they may just be using the nipple just as they would use a pacifier because they're uncomfortable with the feeding, and the act of non-nutritive sucking on a pacifier is soothing to them. Because some of these symptoms overlap with NOWS symptoms, they need to be monitored closely to determine if a diagnosis of reflux should be investigated. Since we know that the GI system is impacted by substance exposure, this should be something that's taken into consideration when a NOWS baby is failing their EAT scores. Okay, so in terms of state control, We know that abrupt changes in infant state may further impact their feeding coordination and engagement. The best state to feed an infant in is when they are quiet, alert, and organized. So we want to try to achieve that calm, alert state prior to feeding. If you have a baby who's very reactive to external stimulation, wake them gently if they're not already awake. The use of slow transitions is really important for our NOWS babies who react quickly and intensely to external stim. Slowing the transition, for example, from the cuddler's lap to the crib for cares, can help reduce the overall peak response to that specific stimulation. You can also feed the baby prior to the diaper change if the baby's difficult to calm after waking and is showing cues and will latch. Providing a snug swaddle to give them more sensory input and increased organization is helpful. Using padding, rhythmic rocking is also helpful. You do want to try to separate bouncing from rocking. We oftentimes put them together, but it may be too much stimulation for them. When we talk about rocking, we're talking more about that forward to backward motion, kind of like a rocking chair. And there's also a swaying motion, which is more of that side-to-side movement. Some babies prefer the side-to-side sway, while others will find it more stimulating. So you can try both techniques and see what the baby responds best to. Broad touch is really important. Increased contact can help them feel more contained, similar to the tight swaddle. Shushing sounds are often helpful for calming. And just trying to keep the environment quiet and dark or dim to reduce rapid state fluctuations can also be helpful. If the baby does not have state changes and is not alerting for feedings, you can try gentle alerting techniques instead, such as a partial unswaddle, undoing the bottom of the swaddle, but maintaining the swaddle on the upper body only to keep those hands at midline. You can do a slow and gentle diaper change, put the lights on a low or dim setting, or provide gentle oral stim to try to slowly transition them from that sleeping state into a quiet, wakeful state. So what can we do? How can we try to improve feedings for our NOWS babies? And as we just reviewed, you want to minimize that external stim, achieve it or maintain a calm state prior to feeding. Use that tight swaddle. You want to make sure hands are at midline so that their organization is improved. You always want to feed them in side-lying position. This allows for improved control of the liquid as well as to allow for anterior spillage when needed. If there's too much fluid in their mouth, you want it to be able to spill out the side. You want to be sure that the infant is in full side-lying position with their head, shoulders, hips, and toes all facing the same direction. Having the head turned to the side but the shoulders and hips turned toward the ceiling is not side-lying and actually makes it harder for the infant to feed. You can start the feed with a non-nutritive suck on the pacifier if the infant is fussy or demonstrating a hyperactive rooting response to avoid transition to that frantic or fussy state. You can introduce the milk gradually at the start of the feed with only a small amount of liquid in the nipple, as we discussed earlier. And you can provide external pacing for gulping or oral loss if you see it. But also, if these are noted, we really should be looking at trialing a slower flow nipple. You can provide rest breaks if the baby's showing stress signs, if they're tachypnic, if they're looking like they're fatigued, or if they're appearing uncomfortable or arching during the feeding. You want to provide frequent burp breaks given the higher incidence of reflux or GERD in this population if the infant tolerates it. And if the infant is having difficulty with state control, shutting down with feedings, or is having difficulty feeding due to prematurity, you may consider smaller volumes with a higher calorie formula or fortified breast milk. This is per the discretion of the medical team, of course, but something to just kind of consider if you feel like the baby is failing those EAT scores and they're not going to meet their PO goals. Consistency goes a long way in the success of feedings and overall tolerance to daily activities with our NOWS babies. They learn from repeated exposure, and the more consistent we try to be, the better prepared they are to participate in cares and feedings. During our NICU competencies this past year, we talked about consistency with nipples and gave the example of batting practice. If you're given a bat of a different size or weight every time you go to batting practice, you will have to adapt to each bat change, and it will take you longer to improve your batting skills. But, on the other hand, if you're given the same bat each time, it will help you learn the timing and mechanics of batting in a more efficient manner. This example is applicable with learning to feed. If the baby gets a different nipple every feeding, they're going to have a harder time figuring out how to be a successful feeder. And this is why I discourage the use of those disposable nipples, and why we really don't want to see frequent nipple changes even when we are using a more consistent commercial nipple like a Dr. Brown's. We want there to be as much consistency as possible, and certainly we have to make changes here and there, but we don't want it to be frequently. The more consistent the practice is, the easier, faster, and more positive the learning will be. Also, I want to note it's helpful to pass on in handoff and even consider taking a minute to document in the chart at the end of your shift what worked for you that shift, so the next caregiver can continue to use the same strategies on their following shift. Because if we have to figure out each time what each baby responds well to, then we're the ones using the different bat at every practice. Okay, so let's talk about what not to do. Faster flow nipples. Faster flow rates only make feeding more difficult as they struggle to manage a larger amount of fluid. As we stated earlier, infants will reduce their suck strength or reduce their suck bursts when there's too much fluid coming out of the nipple. So please be mindful when considering a faster flow rate. Faster is not always better. A mouthful of fluid, even in a seasoned feeder, is harder to manage versus a small sip. Don't automatically think because they can extract more fluid from the nipple that it's easier for them to feed, when in fact it may be harder for them to manage that increased amount of fluid, and you may see them fatigue or begin to have events after a few feedings with that fast nipple because it's just too difficult to manage. They're not ready for it yet. In terms of disposable nipples, I hope that I have gotten the point across as to how inconsistent our disposable nipples are by this point. A variable flow rate is of no benefit to a baby who is having difficulty learning to feed, and even worse for a baby whose own state control varies across feedings. Our NOWS babies are expending so much energy on state control, organization, tight musculature, etc. Feeding is a very difficult task, and we should not ask them to work harder than they have to while doing it. Presenting a consistent flow rate is one of the best things we can do for these babies. And using a disposable nipple, you never know what flow rate you're actually presenting to them. In terms of chin and cheek support, I can't stress enough that these are interventions that are warranted in very few specific situations. These strategies should not be used when feeding a baby unless recommended by a speech therapist. The use of these interventions will increase intraoral pressures, which forces increased liquid extraction from the bottle. This increase in liquid is not infant-driven and may not be well tolerated. By using strategies such as this, or when using a nipple that's too fast, we're making their feeding experience a negative one, setting them up for orally aversive behaviors, and also greatly increasing their risk for aspiration. As I said before, an infant will often decrease their suck strength when they're getting too much fluid from a nipple in order to gain more control of the bolus. But by giving them chin and cheek support, we're taking that option away from them and forcing them to get more volume with each suck, and they no longer have control over their suck strength or the amount of fluid they're getting. This is not a good or safe learning experience. It's also important to know that with preterms, it's not the work of sucking that makes feeding challenging, but the work of trying to breathe in the presence of a flow that they can't manage safely, which in turn disrupts breathing and then manifests in stress signs, tachypnea, events, and/or fatigue. Pulling, tugging, twisting, tapping. Manipulating the nipple is another strategy that is not at all beneficial to our babies. At this age, the suck is a reflex, which is why it's so important that we allow them to learn how to feed in a safe and neuroprotective manner. Pulling, tilting, or twisting of the nipple or any other stimulation that elicits a suck response to get them to take more volume is relying on their suck reflex and is not allowing them to learn to feed without it. Once that reflex integrates at around 3 to 4 months, they can no longer rely on the reflex, and if they haven't developed a reliable, voluntary suck pattern by that time, they end up unable to meet their nutritional goals and are at risk for failure to thrive. I see this with parents often who quickly learn that if they move the nipple, their baby will continue to suck, and they want them to take their whole bottle so they continue to use the technique. They are well-intentioned parents and do not realize the negative impact they're having on their infant's learning. So we just need to keep an eye out for this and educate them when we see it.
Constantly tapping on the nipple just to get that extra little volume in.
Okay, so some things to consider going forward. A little overview of reflux GI involvement. Yes, the majority of our babies have some degree of reflux, but again, just because it's common does not mean it's always normal. Reflux that's impacting PO volumes and weight gain, causing events, choking, and orally aversive behaviors, or is the suspected etiology of respiratory compromise and oxygen requirements is not normal. We know that NOWS babies have a higher incidence of GI dysregulation, and we know that reflux and GERD can be masked by withdrawal symptoms. So if you think GERD could be further impacting feeding in your NOWS baby, please talk to the treating MD and request a speech consult. I am happy to come by and take a look and give you some feedback as well. Chin support. Light chin support can be an effective strategy during the frantic searching that we talked about that we see in our NOWS babies. It can also be used when you see wide jaw excursions, and these things are preventing the baby from achieving a timely and effective latch. But it should be used judiciously, and it should be removed as soon as the baby attains that latch. Chin and cheek support are otherwise strongly discouraged as they increase intraoral pressures and increase the amount of fluid being extracted from the nipple, placing the infant at increased risk for aspiration. Chin and cheek support also do not allow the baby to release the latch, to decrease their suck strength. These are not things that we want to be using, again, unless it's to help them latch onto the nipple, and then we stop immediately once the latch is achieved. Okay, and here's a super short clip of the frantic searching. I'll play it in a second. You have to watch really closely because it's like 3 seconds long. Most often our babies show a lot more of that frantic searching when they're trying to latch. If you see that, this is when you can try to give a little bit of light chin support. You can also try to tip the nipple up so that it touches against the hard palate. This sometimes will elicit the suck reflex, and that may result in a latch. But again, both of these are strategies that should be used judiciously for a short period of time and then be removed when the latch is achieved, or eliminated if you do not find it to be helpful with that baby.
Turn towards it, thank you. Thank you.
And again, super quick, but you can see that back and forth head movement. We often see it a lot longer than this. This baby latched actually very quickly and nicely, but that's a good example of when you can potentially try that chin support or that nipple tipped up to elicit the suck.
Turn towards it.
In terms of nipple changes, a slower flow rate is used to limit the amount of fluid in an infant's mouth to make it easier to control the bolus and coordinate the suck-swallow breath, reducing or eliminating the need for fluid to spill out of the front of the mouth or over the back of the tongue. Less fluid is much easier to control. Consistency is key when working with a baby who's having difficulty feeding. Please try to limit the amount of times a nipple is changed and allow the baby time to learn and acclimate to the flow before changing it again. Generally, a minimum of 24 to 48 hours should be given before another nipple is introduced. Unless it appears to be unsafe, then you can go back to a slower flow nipple. The dynamic nature of a NOWS baby makes it difficult to maintain consistency with feedings in general. They demonstrate frequent changes as they go through withdrawal, rapid state fluctuations, and when warranted, the titrations of morphine, which makes them anything but predictable. My recommendation when dealing with neurologic instability is always to err on the side of a slower flow rate. All that being said, I don't mean to imply that all babies should be feeding from an ultra-preemie nipple, but that's another reason to transition from the disposable nipples to the Dr. Brown system, as they have multiple flow rates that are considered slow flow. The ultra-preemie, preemie, and transitional are all on the slower end, and they are consistent in their flow rates. And one last thing regarding nipples. If the parents have bottles at home that they would like to use, check the nipple flow chart to see if that bottle has been tested and what the flow rate is. The chart is posted in both the PEDS and the NICU units. If the nipple is not on the chart, please talk to speech prior to using it to feed the baby. There are many nipples on the market that are labeled slow flow, but on the contrary, have a fast flow when compared to other slow flow nipples. It's important to know the flow before introducing a new nipple to a baby, especially one that has been having any difficulty or delayed feeding or is going through NOWS. So the takeaway. I hope that this presentation has given you more insight into the complexities of feeding. We know it's a complicated task that's further influenced by the impact of fetal drug exposure. And since these babies are at increased risk for feeding difficulties, it's important that we pay close attention to their cues and respond accordingly. Feeding is an activity that we should be doing with the infant and not to the infant. It's important that we're fully engaged throughout the feedings, just as they need to be, in order to set them up for good quality and safe learning opportunities, for now and for their future. I hope this information provides you with some thoughtful ways to help our babies have positive and successful oral feedings. Thank you so much for hanging with me today. Please consult speech when you have a baby who's struggling to meet their EAT goals. Earlier intervention is always better, and I'm always happy to come by and help out in any way I can.